Namaskar, I'm Dr. Garg. I'm going to talk on the crucial aspect of hair transplant design for men. This is part 3 of chapter 8A, Practical Guide to Hair Transplantation, an interactive study for the beginning practitioner. Part 1 was for the topical zone of the scalp. Part 2 tutorial was for the anti-hairline design and the frontal area coverage. And part 3 is including your temporal triangle, mid-scalp and the vertex. I request you to watch part 1 and part 2. Thank you. The temporal fringe. The hair loss in temporal area causes loss of temporal point and recession of anterior temporal hairline, resulting in a larger forehead. Means the anterior hairline causes the vertical framing of face and the temporal triangle limits the horizontal limits of the face. Means horizontal framing of the face is done by the temporal fringe or temporal triangle, and vertical face limits are decided by the location of anterior hairline. A larger forehead significantly affects the aesthetic appearance of the face. Until around 2000, there was a reluctance to perform reconstruction of temporal lines and temporal points because of the poor technique of hair angle implantation, giving unnatural look. A shortage of grafts was there because harvesting techniques were not advanced, and the future loss in the temporal area means you are just doing implantation in the anterior edge of the temporal triangle or fringe, but the posterior part will lose the hair as a part of AGA. Then this reconstructed part will look as an island. Now the reconstruction of temporal line and the points has become necessary because of the important contribution of the temporal area to facial aesthetic. This also resolves the problem of lowering the hairline. With the passage of the time, we have evolved in harvesting, the instrumentation, punches, machines, technology, and the knowledge has evolved, and now we are able to harvest more number of grafts, better quality of grafts, and even we can harvest extra scalp donor area. We got better quality of instruments for the implantation. So now not doing temporal fringe reconstruction will be an incomplete hair restoration to the scalp, because we have understood that temporal fringe or the temporal triangle has got great importance in the aesthetics of the face. The pattern of hair loss in temporal area, the Mayer's classification means the Mayer has given the classification based on the pattern of hair loss in temporal area. As per him, N is the no thinning or the recession of the temporal point in this category like this. Second is the thinning, T, mild thinning of the temporal area with thinning or the recession of the temporal point. Here you can see there is a thinning and there is a slight recession. There may not be recession even, but the thinning is there, while you can see there is no thinning. So this is normal, and this falls in classification T or the T category. Then the P is the recession of temporal area and the temporal point is in the line of sideburn. Let's understand this. This was like this, but it has receded, and the anterior temporal line or edge or fringe is almost lying in the line of anterior border of the sideburn. So this is called as the P. Then there can be further recession of temporal point and the area, creating a reverse pattern of the normal. This has become almost, although it's not a good example, but the thinning is caused and there is a concave. Usually there is a pointing here, temporal point is here, but in this area it becomes concave. So this is called as reverse pattern or R pattern. The normal pattern is convex, but in this the pattern becomes concave, as I said. The Mayer's guideline for the placement of temporal point. As per Mayer's guideline, the temporal point is a point of intersection of two imaginary lines drawn as follows, like this, which is in class category P. Temporal recession has taken place. So first line is drawn from the tip of ear lobule to mid frontal point. So when you connect both the point, this makes the line 1. The second line is a line connecting the base of the columella or columulolabial junction to point of pupil, center point of the pupil. So this is the second line. And the point where these two lines intersect is the point of temporal peak point. Means this is a temporal peak point. So these are the two lines where they intersect over the forehead is the position of the temporal peak point. Usually it is above and lateral to the lateral most end of eyebrows. That's what you can see. This is the eyebrow superiorly, laterally on the forehead. That's the location of temporal peak point. Now there are some other important things to need to understand. As in my previous tutorial I said, AGA, all the important aesthetic landmarks of the scalp recedes in the same proportion. So when they are receding in the same proportion and when you are recreating them, relocating them or reconstructing and doing the hair transplant, then they should be placed in the same proportion. If you disturb their proportion, means the ratio to of one point to another point, then it will look unaesthetic. So it has been found normally the distance between the midfrontal point and temporal peak point is less than 3 centimeters. If you draw this point much lower, the distance will increase. And if you take TP much posteriorly, the distance will increase and that will not look aesthetic. Now, temporal point is placed above a lateral end of the eyebrow over the forehead, as I said previously. This is the lateral end of the eyebrow. This is the temporal peak point. As we are not aggressively making this temporal peak point, so I am a bit conservative here. That is the reason I make it little shorter than what it was. So this is the temporal peak point. Now the existing hair, we call them the ghost hair. They are the best to help you for the direction and the angle of the graft. So most of the condition, hairs got thinned out, miniaturized grossly, but even then they are there to help you as far as the direction and the angle is concerned. Then the usual direction, if they are not there, then what is normally? Upper zone, you can divide temporal triangle in two zones, upper zone and the lower zone. In upper zone, the usual direction is up forward and downward, like they are facing downward and forward. That is in the upper zone, but in the lower zone, they face downward and backward towards the ear. So this is again important thing while creating the temporal triangle. If ghost hair are not there, then you need to understand what is the normal architectural, means the normal direction of the hair. The angle in the temporal area should be as flat as possible, and if we talk in terms of degree, then they are 0 to 5 degree. The single or two hair graft, follicular unit grafts, are used in the temporal area. It is important that you place at the temporal edge or entry edge of the fringe single unit graft. Then posteriorly you can use 2 unit grafts to make it further stronger. The usual density is 20 to 25 grafts per square centimeter is good enough. Never be aggressive And many times I see only anterior border is thickened, posterior border is not. But here it is reverse. It is better you put more graft posteriorly. If you don't have enough, then don't do the anterior border. Keep anterior border much posteriorly. Because if you implant only in this area, leaving aside this area, with the process of AGA, this area will lose the graft and you will have the island of transplanted hair which will look very ugly. So be careful, understand the aesthetic importance of temporal triangle, what and how much reconstruction should be done depending on the available number of grafts. If you are not sure, it is better not to do it. Then we come to the mid scalp. This is the topmost horizontal area of the scalp. The anterior border is curved line joining the apex of both frontotemporal junction, or the posterior border is the anterior border of the vertex, which includes the vertex transition point. The lateral border on the both sides are limited by the temporal and the parietal fringes. So this is your mid scalp, and these are the lateral border of the mid-scalp. Anterior border is the line joining the two external auditory meatus. This is the anterior border. Posterior border of the mid-scalp is, this is the vertex transition point, so we can call it anterior border of the vertex or the crown. Laterally is the medial edge or upper edge of parietal hump or lateral hump, we can call it. Then the direction of hair in the mid scalp is downward medially and forward in the anterior area. It blends with the temporal area, and posteriorly they blends with the occipital area. This is parietal, this is temporal, this is occipital. This line is the in lateral canthus line. Sometimes it drops down in aggressive grade of baldness. Then there is a need to reconstruct. Anterior border you can understand the frontotemporal angle is there where these both points merge. Now the mid scalp is horizontal, slightly curved. Hair is facing forward in the central area and thus turns laterally towards the side. If adjusting hair is present, follow the angle and the direction. The hair angle is 25 to 35 degree. Usually recommended density is 20 to 30 grafts per square centimeter depending on the available donor area. Multi-hair follicular unit should be used for grafting in the mid-scalp area. So these are the few multifollicular units. The angle is 25 to 35 degree, density is 20 to 30 degree. And when you are reconstructing the parietal hump, you need to take care of the graft direction which you are implanting. Follow the ghost hair, and usually they are present. Now the creation of parietal hump or the fringe. Now this is, let's understand this. In the above, in the advanced grade of baldness, the lateral fringe drops to a point where the lateral end of the frontal hairline may be disconnected like this. Understand this very important point. This is anterior line, this is temporal, and this is parietal. Okay, though there is a hair loss in this area. So what has happened? This has dropped down. This has dropped down, and there is connection which was there between the anterior line and the upper edge of the parietal and temporal fringe got disconnected. So this is anterior line, this is temporal fringe, and this is the parietal fringe. So the connection between these two has been lost. So this is it. So there is a need to reconstruct it. Means there is a need to reconstruct this temporal area. Then there is a need to reconstruct the parietal, and there is a need to reconstruct means transplant in the horizontal portion or the mid scalp area. So in such cases, there is a need to uplift or restore the lateral hump. As I said, you lift it, and that's what the final planning is. This is the lateral hump, this is temporal, and this is mid scalp. These are the zones which are divided. The direction of hair changes in the lateral fringe area. The direction of hair changes in the lateral fringe area. In the upper area, the hair face forward, then turns inferiorly as we move lower, which I explained previously also, the anterior portion of parietal hump blends into the upper temporal area. This is the anterior portion of the parietal hump. Okay, this is the anterior portion of the parietal hump. This is the anterior portion of parietal hump. It blends with the temporal area. That's what you can see. This is temporal, this is parietal, blends with, it merges with the temporal area. The existing hair always help in deciding the angle of implantation of the follicle. Now, this is the what has been done, which I explained you previously. This got disconnected, this got lowered down, there is a thinning, miniaturized hair. So there is a reconstruction of temporal triangle, there is a reconstruction of lateral arm, and there is a reconstruction of the midus, and that's what has been done in this case. Now we come to the vertex. In tutorial 2, we did the anterior frontal zone, and just now we did the mid-scalp. Now we are going to the vertex. The vertex is the posterior zone that lies between the mid-scalp and permanent occipital hair zone. Hair loss in the vertex has less impact on the appearance of the person but has a great impact on the feeling. It's a debate about whether to transplant vertex considering progressive hair loss with limited donor hair availability. Yet there are no clear guidelines to direct the restoration of vertex. See, vertex is the posterior most. Why do we do the hair transplant? For the framing of the face. As I said, vertical framing for the anterior line, horizontal framing the temporal. And when this drops down, and when somebody see you from the side, then if mid scalp is bald and part line is wide, it doesn't look good. So first importance is the frontal area, second importance is your mid scalp area. But if you lost the hair on the crown area, posterior, there is a need to reconstruct. But when? It is not on the first priority, because it doesn't have great impact on your aesthetic appearance, but it has impact on the person feeling. Many times the patient comes and they tell us, we want just transplant here, we don't want here, because they don't understand what is the purpose of hair transplant and how much aesthetic importance this anterior line has got. So there is a need. I'm not telling that there is no need to cover the vertex. There is a need, but on the priority, it is the last to be covered. That's the important thing you have to understand. The pattern of hair loss, age, family history, and donor availability have a significant impact on the restoration. Supposedly, if a patient comes to you in grade 4, and yes, in grade 4 there is a loss in the vertex also, he may ask for it. But initially, in first hair transplant, you avoid it and maintain them on medical treatment. Generally, it is said the vertex is like a black hole where hundreds of hair follicles are utilized, resulting in minimal cosmetic result. Understand this point. If in anterior hairline, frontal area, you are doing it, you keep hair long, then you can cover this area, mid area, and this area by keeping the hair long. But on the posteriorly, the hairs are put in the whorl pattern and they are going in opposite direction. So one hair will not cover the another area, because they are going in this direction, while in the hairline they goes one over another. So this gives them more fullness. So that is the reason if you put large number of hair, even then the cosmetic result in the vertex is less. And there is a need that you must make your patient understand that whatever number of grafts we put, they are going to grow, but they may not create the same impact which they created when you did the transplant in anterior, means the frontal area and the mid scalp area. Otherwise, if you don't explain this, the patient will remain unhappy and he will say, whatever graft you did, the result has not come in the crown area. The restoration of the facial frame by transplanting the front area of the scalp as primary procedure, especially in the young individual. Yes, that's what I explained. At a younger age, the vertex is best treated by oral medication and the topical solution. So, like in grade 2, 3, 4, even I'll say up to 5, it is better you treat them by medicine. And if the area becomes bald and the patient has got donor area availability, then and then you can think of transplanting the vertex. The luxury of transplanting vertex can be taken after completion of restoration of the facial framework of frontal and the mid-scalp area. Okay, I explained this. Though the vertex does not play a large role in the appearance of the patient, but not restoring the crown, the hair restoration of the scalp is called as incomplete. As now we know that donor area is available, and as of now, harvesting and implantation have improved, and it is possible to use non-scalp donor area to provide extra hair follicle, which improves our ability to cover the vertex. Now, the detailed discussion with the patient is necessary before taking any of the above options. It is important to visualize future hair loss in the vertex before undertaking a transplant. The easy way to assess this is to wet the patient's hair. This simple procedure will give useful information about the future hair loss. The visualization and demarcating the thinning zone becomes much easier when you wet the hair. These regions can be marked, and by blending graft into this area of hair thinning will limit the chance of showing an unnatural balding halo as a result of progressive hair loss. So many times the patient says, I have enough hair, but the best examination for the vertex, no matter vertex, even the other area, if you wet the hair, wet the scalp, then you will really come to know how much is the thinning, how much is the volume of the miniaturization is there. That will give you an idea that what areas to be transplanted, and that needs you should understand and you should explain to the patient. Now the various options. What are the various options? Although we are discussing all things in detail, but let's go one by one. Do not do transplant at all. This is one of the option. Another, transplanting the entire vertex with uniform density. Many times patient ask, sir, you can put in low density, but you put some hair because it shines in the pics. So one option is that you are covering the entire area with the low density, but the patient should know that you have put in low density. Then transplanting entire vertex with graded density, less in the center, more at the periphery. This is important for you to understand. Usually we think that you put more hair in the center and less hair on the periphery. If you do, because of the AGA, there will be further loss of the hair, and there will be an island in the center, and there will be a halo around, blank space, so it will look bad. So more hair in the periphery rather than in the center. Transplanting only at periphery is one of the options. Then transplanting the uppermost zone of the vertex with hair facing downward. This is like a good option. You transplant the upper zone and put hair those in the downward direction. So when they comb, the hair will go on the back side and lower side, and they will cover the remaining bald area, creating an anterolateral border of the vertex only. This is important. I prefer this if I am not doing the vertex, but when I am doing the mid scalp, I always try to cover the lateral area, anterolateral area, or the parietal eminence I will call this, because in the when the part line becomes widened, then this area becomes prominent, so you can do this area transplant only. Augmentation of visual density by scalp micropigmentation is also an option. Utilize body hair, donor hair follicle along with the scalp as a combination grafting. I have read the paper, my paper has been published on this. Combination grafting, the use of beard, if beard not available, then the chest hair is a good option to cover your vertex. Now the boundaries of the vertex, they are the zones, upper zone, middle zone, and the lower zone, and there is a wall. Let's understand. The vertex transition point makes the upper border. This is the mid scalp area. the superior portion of the occipital fringe, this is the occipital fringe, superior portion of the occipital fringe makes the lower border. Lateral border is the parieto-occipital, this is the parietal, this is occipital area. So parieto-occipital fringe makes the lateral border of the vertex. So these are the boundaries. It can be divided into upper zone, middle zone, and the lower zone, and the whorl lies mostly in the mid zone. Means lower part of the mid zone it lies, and usually the whorl position may be on the left side, but there can be two whorl, there can be single whorl, and the location may vary. So the hair architecture in the vertex, this is the again important. The hair distribution, the pattern in the vertex is unique and complex. You understand this? How complex is this? The hairs are changing their direction. See here, here is a whorl. This is on the right side. The whorl is in the upper zone, not in the middle zone as I said previously. So it is in the upper zone, and the hair is whorl is on the right side, and the direction is something like this, then it became like this, then became like this, and here they are going. So see, the pattern is very variable and the complex. Restoring normalcy means maintaining a normal existing hair pattern. It requires a careful observation of the existing patterns and loss with anticipated patterns of the hair loss. So Ziering's study has done and given the classification when there can be also called as S pattern, which describes a clockwise whorl. Here the whorl is clockwise. Hairs are going like this, here are going like this, here are going. So it's called as S pattern or the clockwise. Another is there can be reverse. You can see previously hair are going like this. Now it is reverse pattern. This is going like this is also called reverse S or Z pattern. You can call this. Then there can be combination of two with the adjacent whorl SS. So two clockwise patterns are there. We call it SS, or there can be one S and one Z pattern. So this is just you should know it, and if the hairs are there, then you can follow their direction. If they are not there, then you can make a single whorl. Also, the angle of implantation in the vertex, the best guide is the existing hair, the villous hair, ghost hair. Most of the time, there are a few thin hairs left which help in determining the native hair pattern. These are the ghost hair. Lot of ghost hairs are there, so just follow them. If patient does not have any whorl, then you can put it on the side where he is doing parting. It is better to place a single whorl off the center precisely on the side of the part with the arch matching the part, usually male part on the left side. So you put at the in the middle zone and slightly on the left side and making it clockwise. So the direction of the hair, if the patient parts his hair from left to right, the whorl should be designed clockwise on the left side of the head so that the upper limb of vertex arc matches the hair part, which will facilitate the hair styling. Let's understand. So you have put this is the part line. So when you are making it clockwise like this, then they will matches with the part line because he is parting here, left hair is taking on the right side. So they will match. Now slit creation, I use the thigh massage chair, but you can use on a routine operating table or dental chair in prone position or in lateral position, whatever it is, which prefer. This is one of the case. These are the angle of implant. It is always advisable to start implanting from the center of the whorl and go lateral periphery. Mostly smaller FUs 1, 2 to the center of the whorl and the lower half of the crown. Larger hair follicles are used for the upper arch of the vertex, while 3 years FUs grafts are placed lateral to the whorl to create a sweep of hair that transit from upward to a downward direction. So it's important that here you put multifollicular graft In the center, you put single or double follicular unit graft. If reconstruction is needed in the vertex transition zone, two hair follicles are used to give more density and to blend smoothly into the mid-scalp area. A mix of one and two hair follicle units are placed into the circumferential fringe laterally. The upper arc of the vertex needs a higher density grafting. This needs more visual density to the lower vertex area and to the posterior mid-scalp area. So you put the more density here. So this will give a coverage to the lower area and this will provide a fullness in the mid-scalp area. Now this is one case, 35 years, we did the hair transplant, reasonable coverage, just I think it was 5 or 6 month result only. So thank you. The next part 4 is the author's method of designing of the anterior line, and last one is another important area. You must see that the tutorial number 5 in which the entire chapter has been covered. That talk was given during the HairCon 21 in which I have covered all the cases, case discussions, everything is there. Thank you. Thank you very much.